We would like to introduce you to aseptic technique in the oral surgery operating rooms and indicate the manner in which you conduct yourself and the patient is handled in order to preserve the sterility of the armamentarium and the equipment as we work in this clinic. You'll see that I am attired in a scrub shirt, which you will put on when you come to the clinic. It is laundered and clean. It has not been autoclaved. It will also have a name tag which will identify you, and you will wear a cap. These are also laundered for each occasion, and the tie is in the back, and this will prevent loose hair from coming out and getting into the operative field or the areas that we are considering sterile. Modified caps for other hairstyles are also available. But in this manner, we will present our opinion. On some occasions, you will have a cold, upper respiratory infection, or your patient may have an upper respiratory infection. In that instance, you'll use a face mask covering your nose and mouth. It has a small metal band which can contour over the bridge of the nose, and it's tied back both above the occiput and below, down on the neck. And this will protect yourself and you'll protect your patient from the exchange of pathogen in the operation that you're carrying out. So if you have a cold or your patient has a severe upper respiratory infection, or there's any other reason, sometimes in certain types of surgery that are more vulnerable to contamination than others, we also put on a face mask. When you are then in the clinic, your patient will enter, and the assistant or nurse will bring in the patient and the patient records. And those are on this shelf, and the patient's belongings will be placed in the cabinet in the shelves that are down below. We'll leave that open for a moment just to show you that in addition to the storage of the patient's belongings on the bottom shelf, this cabinet contains a number of other containers and supplies. To control the hair in the operating field, a cap is placed over the head. This both protects the patient's head from any possible contamination from the previous headrest user, and also controls the hair so that it does not get attracted to your hands as you are operating with gloves, where static electricity tends to attract hair. The draping of the patient proceeds with a sterile drape, which will go over the front. You'll notice how it's being handled, that the exposed surface is not contacted by the assistant, and that area will remain sterile. Patient should be instructed not to touch the front of this drape, which remains sterile. You might say, well, those are the patient's own organisms and it doesn't matter, but the flora on the hands is different from that of the mouth, of course, and we try to preserve that zone of sterility. Before we proceed, we will look at the records, and each patient will come into you with a complete record of this sort, and the front sheet will contain the identification aspects, and the radiographs will be here. The radiographs are mounted and are placed in a view box, which is located here, and they then will be available for your careful review as you get to the radiographic section of the patient's records. As you approach the patient for a tentative preliminary examination, before your hands are prepped for the aseptic technique that we will be discussing in just a moment, we will step over to the area of the sink where sterile tongue blades are maintained, and we're able to pick one of those off without contaminating this end of the blade that's going into the patient's mouth. And we'll then proceed with a preliminary cursory evaluation of the oral cavity, checking out for the correlated symptomatology and the findings. We'll conduct a cursory preliminary examination then entirely of the mouth and jaws, and after our hands are prepped, we go into a more thorough palpation and evaluation of the area. But for the preliminary entries on the clinical examination of the oral cavity, this would be the approach, and we then would turn to the preparation of our hands. You notice I just discarded the tongue blade in one of the waste receptacles that is here. In the preparation of the hands, we use gloves in oral surgery. The gloved hand provides a surface which is readily prepared, since it lacks irregularities and porosity. It is prepared with the hexachlorophene soaps and detergents that are used and can be very rapidly re-scrubbed. And it is primarily for this purpose that we operate in a gloved hand condition. A second rather important to you reason for operating gloved is that the gloved hand protects the operator. And when we are working with sharp instruments and around irregular teeth, and particularly around areas that are often infected, it is appropriate that we protect our hands in these instances. The organisms from hepatitis virus on through the common bacterial pathogens that you'll encounter in abscesses, these things need your own protection as well as the protection of other patients that come to oral surgery clinics. So when you're dealing with these contaminated conditions, we should do everything we can to preserve sterility of the field. We'll look at the preparation of gloves now. Gloves are purchased ordinarily. The size of your glove is the same or a half size smaller than dress gloves. Rubber gloves are purchased in this particular form, and the surface should be powdered. This powdering of surface allows the entry of the hand in a simplified manner rather than getting hung up on the glove surface itself. In a hospital operating room, the gloves are autoclaved. These gloves are just clean, and that is the primary difference. And you will be working with clean gloves, the surface of which will be scrubbed for the given case. We'll demonstrate simply how the powder is applied. It is sprinkled on the gloves without any great volume, and it is worked into this outer surface of the glove. After the exterior then of the glove has been powdered, the outside is powdered, the inside is not. These gloves then are simply inverted. They're turned inside out so the powdered surface gets in. If you then close the cuff of the glove, you trap some air, and that air can be used to extend the fingers of the glove outward. So we now then have powder on the inside so that the hand will slide into that rather well, and we'll do the same thing with the other glove. And we then will have gloves that have inside powdered surfaces that are going to admit the scrubbed hands much more readily. So we'll return to these gloves in a moment after we have scrubbed our hands. As you are preparing your hands in surgery, we'll go over to the scrub sink, which is located in this corner. It is operated by this knee control, which avoids any use then of the prepared hands in controlling the water supply. As you begin the preparation of your hands, any rings and jewelry should be removed from the forearm and hand and placed to one side, preferably in your pocket so you don't forget them. We'll then begin the scrub of the hands, and this will depend upon the relative initial cleanliness of the hands. These tissues are impregnated paper that has been impregnated with hexachlorophene detergent soap, and they will supply both a surface on which to scrub and a supply of. So we will begin the hand preparation. You will have previously cleaned your nails of any dirt, and if your hands are particularly soiled, you may wish to begin the introduction with the use of a scrub brush as well. Those are in each of the operating rooms, and you can use that as a preliminary scrub. This will be then the preparation of the hands. As you are scrubbing, it is important that once you've started the preparation of your hands, that you get into all surfaces, get in between the fingers and around the wrists and into the upper forearm. As the soap is rinsed off, rinse it in a manner that the water drains down toward and off of the elbow rather than keeping the hands down so it drains the other way. Your prime purpose here is the preparation of the hands, not the elbows. So your hands should remain as clean as possible throughout this preliminary scrub. This is much abbreviated from what it would be in the operating room because you are not going into sterile gloves. So your hands are clean now, and we'll dry the hands in this manner, taking a paper towel from this container. Again, keep the hands high. Sometimes more than one towel is necessary to get them dry. And we will prepare this skin surface by applying more powder. The powder that we'll use on the hands is packaged in a cream form, and that's located here in these packs. These packs are then torn open. They have an inner package that we will obtain, and in this inner package is the tube-like cream powder. And you can see that this cream powder then is just expressed on the hands. It's one way of controlling powder so that it doesn't spread all over the room in a big cloud. The powder then is applied to the hands. It dries very rapidly. The vehicle is a rapidly vaporizing solution so that the hands now are covered with powder. And we will return to these gloves that we had prepared. And now with a powdered hand surface and an inner powdered glove surface, there is no difficulty in sliding the gloves onto the hands. So we'll grasp the glove at its cuff, insert the hand inside the glove, and pull it on well up over the wrist so that each of the surfaces is covered. Now we have hands that are clean inside of clean gloves, but the cleanliness of these gloves needs to be improved by another preparation. Now we are covered with this surface that is rapidly prepared, unlike skin, and we can very rapidly prepare it again here at the scrub sink. We'll return to the scrub sink, wash these surfaces, select another Fisahex tissue, and proceed with the preparation of the gloved hand. When we conclude this preparation, you can see the lather works up quite readily, and we very quickly will cleanse this rubber surface of all organisms. If during our work we should contaminate our hands, this procedure then is rapidly repeated. Once the gloved hands have been prepared in this manner, they should be kept away from you and above your waist. Do not let the hand drop below waist level where it can accidentally get contaminated. You have now a gloved surface that is quite clean, and we can proceed to operate in the field and to look at the tray where the sterile instruments will be kept. I'd like to suggest that this is a standard tray setup, and when you enter the oral surgery clinic, one of the assistants will have prepared this area by covering it with a double thickness of autoclaved linen, and in a tray cover we'll have selected the suction hose that you see here, and it's a cup filled with sterile water and an irrigating bulb. The paper cup is for disposable items such as the anesthetic pules and ampules, so that they do not get left out in the tray to be accidentally broken and allow broken glass to be carried back into the operating field and accidentally lacerate the patient. So this is one place where that type of material will be discarded. Suture needles, other extracted teeth that are going to be discarded, anything like that goes in that waste receptacle. Here are our initial supply of sponges. We will use these in many aspects in surgery for the hemostasis that's necessary in certain parts of the examination. We can proceed further with the examination with the mouth mirror, and we would then do that, completing the inspection and the palpation of the field to make any additional entries on the examination findings for the particular patient. After arriving then at our diagnosis and a treatment plan, we are ready to increase the instrumentarium for the particular case at hand. And to do that, we select the instruments that are provided for you and for your use in oral surgery from the cabinet area where they are kept sterile. The cabinet, as you see, is provided with two transfer forceps that are located here. One of these has been placed for this particular patient. That is labeled patient forcep. The other is the general room transfer forcep. Both forceps have completely sterile beak areas, these areas out here. However, the handles on this one are clean for this particular patient. And so we can use this transfer forcep, work on the patient, select another instrument if we need it, and do not have to scrub our hands again. They are kept protected in those tubes. The other transfer forcep available for others that come in the room whose hands have not been prepared, so that if an assistant comes in and you ask her for something, she can use the room transfer forcep and obtain the instrument and put this back without contaminating this area. The sterile instruments are kept in this cabinet. The cabinet is kept covered to keep dust, debris, and contaminants out, and as we would think about the procedure that is planned, we would select the instruments from the beginning to the end of our operative procedure and then close the cabinet. We would select, for example, a curette, a double-ended curette, to check for soft tissue anesthesia around the necks of the tooth that's to be removed. As we bring the instrument over to the bracket tray, we will not touch the bracket tray with the transfer forceps. Instead, we will drop it flat. If inadvertently, after working on this patient and bringing this patient's organisms and pathogens back to this tray area, if we touch that tray area with this transfer forcep beak, we therefore will carry those organisms the next time we use the instrument back into this sterile area of the cabinet, which we definitely wish to avoid. We'll go through some of the contamination traps, accidents that you can have. We would indicate that this sterile water is dispensed if we wish to irrigate the field by filling the bulb, and then to control more specifically the place where the fluid will be directed. These small tips are used, and whenever putting tips into rubber equipment, if you moisten both of them, they'll slide in a little more readily. This then is a way in which this dispenser of sterile water is held, and if you hold the bulb in your hand like this and just grasp the tip between index finger and thumb, you can squeeze the bulb and direct the stream exactly where you wish it to go. The suction is here, and the suction tip, once again, if moistened, will slide into this tubing more readily. And here you have then the aspiration equipment ready to go. The aspirator has a hole in it. The maximal negative pressure is obtained if you put your finger over the hole, then that's maximum aspiration. For some areas that are rather delicate where you don't wish the same volume of aspiration, then you may wish to decrease the negative pressure by taking your finger off of the hole for that particular part of the operation. The suction is operated by the control knobs down below this stand. Therefore, to turn on the suction equipment, you would either request that the assistant do this by turning this knob open, or in the event that you had to do it yourself, you'd need to re-scrub, because that is one of the places where we can have a source for contamination. Returning to the tray for a moment, there are times when you may contaminate an instrument and it may need to be replaced. Let us, for example, state that we have contaminated the tip of this suction by hitting it against the chair or someplace. We'd want to discard that, and we would discard it into the instrument sink that is over on the wall opposite the scrub sink over here. The contaminated instrument is then gently discarded in the sink without your touching the contaminated sink area. While we are here, you'll notice this covered pitcher, which is the source of the sterile water that is used in the cup on the sterile bracket tray. When you run out of sterile water, this is the reservoir that is used. The handle of this is contaminated, and it will be necessary for you to re-scrub after you refilled the cup. With these contaminated hands, if we wanted to get a few more sponges before we re-scrubbed, we would not use the patient forceps. We could, however, use the general room forceps, come over here to this drawer and obtain a new supply of sponges and drop them over here, close the drawer again, and return this general room forceps. Now our hands need to be re-scrubbed. We'd return to the scrub sink. We'd go through the same operation that we had carried out before. And as you run into these contamination pitfalls, your guard is kept up because each time you have to re-scrub, and that is time consuming. Among some of the contamination pitfalls that are here is the preservation of the sterile areas. The most important of these is this bracket tray, and where you're using additional or unusual equipment, such as a biopsy bottle, you don't bring that biopsy bottle in, as we could show here. The biopsy bottle or paper is not put on that tray. If it is, it contaminates the whole thing. So don't let anybody come in and place contaminated equipment on this sterile tray where you're going to continue to work on the patient. The other potential pitfall for contamination, the biggest one of all, would be the contamination of the interior of this supply cabinet. If you reach in there with your hands, if you contaminate it with a transfer forceps that it carries organisms in, then the entire supply has to be removed, the entire cabinet taken down, all instruments re-autoclaved, and this is the cardinal sin in the breaking of the aseptic technique here in oral surgery. The other possibilities, as we mentioned earlier, are letting your hand drop down to your sides, touching your clothing, pulling out fountain pens, writing in areas, and then going back to the field. We wish to avoid these potential contamination traps. The handles of the light have been prepared by scrubbing them down again with Physohex in between, so that this part has had a hexachlorophene scrub. Other parts of the light have not been prepared and are potentially a zone of contamination. So when you grasp the light, grasp it just on the handles that have been scrubbed down, and you'll avoid that source of contamination. The buttons on the chair for changing chair position are scrubbed down between each patient, again with hexachlorophene. Would then be at, hopefully, preserving aseptic technique. We'd be at the conclusion of the procedure and would be ready to dismiss the patient.